Good evening, everyone, and welcome back to the Primary Care series hosted by the Primary Care Education Department at City St George's. My name is Roa Albaderi. I'm a GP and clinical lecturer at City St George's. Tonight's seminar, titled Guidelines or Tramlines, Is There More to Primary Care Than Following Rules?, invites us to consider the growing tension in primary care between standardised protocols and individualised care. And over the past 30 years, healthcare has become increasingly performance driven, particularly in primary care, with frameworks like QOF focusing on specific measurable outcomes. And whilst these have improved public health, they've also led to an overwhelming reliance on guidelines, and sometimes at the expense of nuanced patient-centred care, arguably a cornerstone of general practice. So tonight, to help us navigate through this, we're joined by Dr Rupal Shah, a GP and Associate Dean with NHS England, and is also the co-author of Fighting for the Soul of General Practice, The Algorithm Will See You Now. In this book, the authors share their experiences as GPs working within a bureaucratic, protocol-driven system, highlighting the impact of guidelines, technology, and that loss of personal relationships in patient care. And the stories raise some important questions about how we balance regulation with the core values of general practice. So we're excited to hear Dr. Shah's perspective on these issues in primary care and how the future of primary care may look with some of these competing tensions. So I'll now hand over to Dr. Shah, and please do post your thoughts, your comments and questions in the Q&A box throughout the seminar, and we'll try to address these at the end of the session.
Thank you so much, Roa. I'm really happy to be here. Thank you very much for inviting me. So as Roa says, I'm a GP. I've been a GP in the same practice for 20 years now. And the book that I wrote with Jens, it comprises anonymized anecdotes, and we're kind of trying to work out, is there a soul of our work? And if there is, should we be fighting for it? But, you know, it's quite difficult to talk about soul. It's not an easy thing to kind of define in this context. So if it's okay, I just wonder if I could read you a short excerpt from the book, which I think sort of summarizes what I mean by soul. I'd been trying to contact Joan for the past week. A chest x-ray taken during a recent hospital admission for pneumonia revealed possible lung cancer, but she self-discharged before she was told the diagnosis. She didn't have a landline, and she wasn't answering her mobile phone. I was walking past her tower block on my way home from the surgery, so I decided to try and tell her the news in person. I first met Joan about 15 years ago, soon after I started at the practice. She grew up in a poor area of Glasgow as one of 7 children. She had invisible wounds from her childhood, which revealed themselves as I got to know her. It might be why she had fallen out with all her siblings over the years, except for one older brother who lived nearby in London. She told me that he had always looked out for her when no one else did. She was quick to notice any real or perceived slight. Enough people had let her down in her life to make her frugal with her trust and quick to withdraw it. Because she wasn't housebound, I'd never seen her at home before. She lived on the 7th floor of a tall grey council block. The paint was peeling from around the front entrance, and when I got buzzed in, a heady mix of cannabis laced with urine hit me in the face. There were different lifts for odd-numbered floors and for even, but in any case, on that day, neither lift was working. So I took the stairs, feeling a cold draft on my face as I climbed up. Joan opened the door cautiously with the chain done up and was clearly astonished to see me. "Oh my God, it's bad news, isn't it?" she said as she let me in. I sat with her in the front room, recovering my breath. We were still for a few moments and neither of us said anything. I took in her front room, the worn sofa, covered in a colourful knitted blanket and magazines, the single armchair and the television, which she switched off when I sat down. I could see her more clearly than ever before. We looked at one another and it seemed brutal to break the silence and end that moment. "Joan, I don't know, but I'm afraid it might be. I'm so sorry." I told her about the x-ray. I was expecting an outpouring of shock, but actually She was surprisingly calm. You know, I'm not surprised. I thought it would be that. I knew all along, really. It's why I couldn't stay in that hospital any longer. Well, I'm just glad it was you who told me. There was a moment when both of us had our guards down. We could acknowledge that life can deal you these curveballs. I couldn't help her to dodge it. All I could do was stand next to her when it came spinning towards her. Well, I'm just glad it was you who told me. Those words kept echoing my head for a long time afterwards, bringing tears to my eyes unexpectedly. The privilege of being allowed to stand next to her, of being part of each other's stories, those moments of connection that dissolve me, that bring the best bits of me out of me. Now, that's why I keep working as a GP. So that story is, as I said, it's from the book. And for me, that kind of represents the soul of our work. You know, the bits I'd say that aren't about the medical knowledge, but the ones that are about emotional connection, and maybe the ones that bring into focus our own mortality and our limitations. Don't want to quote you to death, but I just wanted to. There's a beautiful quote from Anatole Broyard, who was a writer and literary critic. He died of prostate cancer, and he wrote about his journey with prostate cancer in his posthumously published book, Intoxicated by My Illness. You know, he put it like this: not every patient can be saved, but his illness may be eased by the way the doctor responds to him. I swap doctor for clinician. You know, the world has changed quite a lot since in the last 30 years since this was written. And in responding to him, the doctor may save himself. But first, he must become a student again. He has to dissect the cadaver of his professional persona. It may be necessary to give up some of his authority in exchange for his humanity. In learning to talk to his patients, the doctor may talk himself back into loving his work. By letting the sick man into his heart, they can share, as few others can, the wonder, terror, and exaltation of being on the edge of being, between the natural and the supernatural. So, you know, we've got a short time together, but I'd really like to consider with you whether there's still a place for soul in 21st century healthcare, or if the idea is an anachronism. You know, I said at the beginning, I haven't given an exact definition of soul because I find that difficult to do. But I think it's something that emerges when, alongside our medical work, there's acceptance of love, humility, fallibility, moral purpose, and duty. I just wonder if I could give you a little bit of context, you know, to think about the place, if any, that soul has now. I wonder if I could kind of talk about how medical culture might have changed over recent decades. Don Berwick is a very high-profile academic and clinician in America. He's helped to shape health policy at sort of very high levels, and he's advised us in the NHS as well. And he talks about 3 eras of medicine. So I remember era 1 because I'm old, from medical school. So that was, you know, when I was a junior doctor, basically doctors, I will say doctors, you know, on purpose, doctors were God. Doctors could make decisions based on their personal opinion. There were really very few guidelines. It was before NICE. But, you know, despite the terrible hours, the crappy working conditions, power imbalances, prejudice, racism, it felt as though signing up for medicine was a life choice. You know, it was like quite a lot more than a job. Just remember this quote from medical school: I don't understand all this work-life balance stuff. I live to work. That's what a surgeon told us on one ward round as medical students, my husband and me. We met when we were 18. Same surgeon, by the way, who's going to operate on my 15-year-old daughter for her scoliosis next year. You know, it made a big impact on me at the time. I don't know, I must have been sort of 21, 22. it felt like it is kind of what I should be aspiring to. No, like it's quite controversial now, I think, to even say that. But if work is life, then maybe soul has a natural space and it's found in the gaps left by other ideas that were implicit but pervasive: duty, responsibility, calling. I'm not, by the way, asking for a return to era one at all. But I think maybe I'll pause there and see if Roa wants to come in and comment.
Yeah, actually, we've just received a comment. Perhaps I'll say this out loud. So somebody's posted, don't you feel the system doesn't accommodate for the soul? We often would like to practice, and increasingly so, it's idealistic, but not always practical.
Absolutely. Yeah, I think that's what writing that book and the podcast and everything else that I do, it's an attempt to articulate that. I think probably my position on soul in medicine is quite clear, but I agree that the context is really sort of squeezing it out. So I think that all of you and us should be fighting perhaps for a change in the context so that there is space for soul. Um, this kind of coming back to the slides, the pictures here are taken from a book that I recommend everyone reads called A Fortunate Man. I don't know if people have heard of it. A Fortunate Man by John Berger. It was a complete classic. When I was training to be a GP, everybody recommended it to me. But it was a book definitely set firmly within what Don Berwick calls Era One. It's all about the soul work of a GP, John Sassel. It was based on a real life doctor called John Eskell, but John Sassel was a name used in the book. And his life was completely inextricably linked with his patients. He knew all their stories, and he was also part of them because he lived in the same village. Berger writes about John Sassel's sense of duty towards the people he serves, the toll the work takes on him. I mean, he took his own life after he retired. The love he feels from his patients, that he receives from them, all at a time when, medical options were quite limited and death was much more part of life. The photos are just beautiful. They just tell the story, I think. But of course, there was a very dark side to Era One. Nobody should have that much power. And I think it became much more apparent over time with high-profile cases like Harold Shipman, which eroded trust, obviously, in the medical profession. And along with this, there was a kind of rise of evidence-based medicine and a proliferation of biomedical treatments. And it sort of meant all of this, that science and certainty sort of shoved out the other ways of knowing. And I mean, like intuition, personal knowledge, ethical knowledge. They became the kind of soft stuff. So, I would say that if we're aiming for high quality, personalized clinical care, then for me, after 20 years of practice, I'd say that, of course, you need to know your stuff. There's no question that you need to learn the facts and be up to date with knowledge. And you do need to know the guidelines, but I'm convinced that relationships and relational care contribute equally to high quality personalized clinical care. But I kind of feel like we're more like this now. And we're in what Don Berwick calls Era 2 medicine. So although we're aiming for high quality personalized clinical care, there's a real privileging of guidelines, of certainty, of of biomedical knowledge above other kinds. And I think there's lots of influences on this, aren't there? There's our regulators, the GMC, CQC. In general practice, we have at least 100 different targets. So when I'm seeing a patient, there's like these little yellow triangles in the bottom corner of the screen. So they could be telling me something really profound about their story. And what I'm seeing is ask them about smoking, check their blood pressure, they're overdue for their flu vaccine, they're overdue for their pneumonia vaccine, um, you know, cholesterol not to target, all of this stuff. And we're kind of thinking about healthcare a bit like a sort of factory model about efficiencies and outputs and throughputs and all kinds of things. And, you know, I wonder if we are missing the point. Ro, I don't know if you'd like to come back in here at this point. I can't see, of course, any comments or what people are thinking.
Yeah, no comments at the moment, but I guess I'm just thinking about balancing that protocol with the personalization for the patient's journey, with the limitations that the system has, such as time. And I don't know whether you have any practical insights as to how we can balance the two.
I'm definitely going to come on to that, because I think that we need to rethink our conceptualization around efficiency. So I think short appointments where you're only addressing cholesterol or blood pressure or another thing which is a risk factor, it's not a disease, without engaging with who the patient is, what matters to them, all of this, I think it's honestly inefficient and ineffective. And I was going to talk a little bit more about that in a bit, because I'm going to link it with something called failure demand, which I'll talk about a little bit more just in a bit, if that's okay, Ro. So I think, you know, as I was saying, we went from era 1 to era 2 quite abruptly. It was a huge culture change, and I was kind of part of that. I think I was a GP resident when, you know, the new contract came in with the quality and outcomes framework. That's a very UK specific thing in general practice. It's all these targets I was talking about. It, you know, when I was training as a medical student, there was very little regulation and all of this, but it all kind of came into existence around the same sort of era. Regulation, accountability, measurement, it all began to kind of frame our practice. And I think some of it is useful, some of it is probably essential. We do need to be regulated. But a lot of what goes on in era 2 is predicated on there being certainty and there being a right and wrong answer and a clear pathway. And I say that, you know, healthcare, life really isn't like that. That's not how people are. You know, the idea that clinicians can be interchangeable as long as we're all placing our patients on the correct conveyor belts. There's this idea, sort, fix, or send. The first chapter of our book, Jens and I kind of talk about this a bit, talk about patients that can't be fixed in this sort of sort, fix, or send paradigm. You know, the awkwardly shaped parcels that jam up the conveyor belt of general practice. You know, and then what should we do? Should we pick them off, leave them on the pile of discarded goods? Or do we pay attention, give time and love in an environment which isn't designed for it? No, it's the people with personality disorder, the people with chronic pain, chronic mental health conditions, the ones who were exposed to childhood trauma as they were growing up, who've had horrible things happen to them. This kind of model doesn't work very well. Now, I think, as the comment kind of indicated earlier, the culture created by certainty and the absence of nuance is hostile to soul work. There's no proof that something as personal and invisible even exists, but it certainly can't be standardized. So era 2 approaches are really keen on efficiencies and on productivity, but policies are often designed with this factory model in mind rather than the actual human world. I think there's an assumption that the more workers you put on the conveyor belt, the more output you'll generate, the more disease you'll treat or prevent, and that there's standard pathways for everything. I really value being part of a multi-professional team in primary care, but I can see how the factory model doesn't fit the real world of primary care and how easy it is for care to become fragmented as patients see a pharmacist for their COPD, a nurse specialist for their hypertension, a GP for their depression. You know, this thing that a colleague called David Sigmund, who was a GP and a psychiatrist, says, sorted, fixed, and sent all over the place, with nobody understanding the story, the context, what matters, how it all fits together. And I'd say it generates a lot of inefficiency, and you can't solve it by more of the same. That's the feeling that, as a practicing GP, I've had for a long time. But in the stories that I wrote with Jens, I think we didn't really have the language to prove that. This is a real image, by the way. If you type in suffer into our clinical software, you can't find a match. So I just wanted to kind of come back a bit to Roa's point, and it's a bit of a light bulb moment for me when I first heard about failure demand, which has been around as a theory for a long time. I just hadn't heard of it. So I think it was first put forward by Professor John Seddon in about 2012, and then expanded on in a book written by Nick Downham and Murray Anderson Walker called Improving Quality in Healthcare. And what they mean by failure demand is a demand that arises because of failures within the system. And it's so you've got demand that's like true demand. They call it value demand. So that's, of course, if you're working as a clinician and someone comes in with a chest infection or angina or a broken leg, they need treatment, right? So that's true value demand. But then what about the demand that's generated because we're not listening to the story and we're not injecting soul into our work? So it's the people who have to come back time and time again until they find someone who will listen to their story. So I'll give you an example. This is a bit more, sorry, slide. I should have changed it a bit earlier. Imagine a frail 85-year-old man. Okay, we'll call him Mr. C. And so Mr. C comes in and he's complaining of non-cardiac sounding chest pain a few weeks after his wife dies. And, he's got several comorbidities. So imagine he's got CKD stage 4, he might have heart failure, type 2 diabetes, and then, so a GP he doesn't know sends him to A&E because of this chest pain as a precaution. But A&E is 30 miles away, and he's sent there without his hearing aids because obviously the GP doesn't know that he needs hearing aids and that he forgot to put them in that morning. So he spends 24 hours there in A&E before his son finally persuades them to let him go home, which he does. And he's got a new diagnosis now of paroxysmal atrial fibrillation. And A&E recommends several other investigations like a 72-hour monitor, an echocardiogram. A&E advises the GP to organize these. And so, the letter comes through, it comes through to someone else, not the GP who didn't know him anyway, but who sent him to A&E. It comes and a different clinician sees the letter and it comes through workflow. And for efficiency's sake, it's so someone requests these investigations, the monitor, the echocardiogram, and nobody's ever met Mr. C or knows him. And whether actually organizing a 72-hour cardiac monitor and an echocardiogram in someone who's frail and who's 85 and whose life expectancy is limited, right? He's probably got a couple of years of life left. Whether these tests will make a difference to anything, that's a moot point. But the results will have to be reviewed, and it'll involve more appointments, more referrals, more demand on the system. So that is failure demand in Mr. C's story. And it's unlikely that anyone in all of this, and there's loads of different appointments now, aren't there? A&E attendances, appointments, letters, investigations, but has anybody explained to Mr. C or his son the absolute risks and benefits of treatment? Has anyone asked him what he wants, in the few months or years that he is likely to have left? Again, I'm going to just pause and see if, Ro, if you have any questions, if this is making any sense, because it's hard to get a kind of sense of how things are.
Yeah, we've had a few comments. So somebody's commented, protocols or guidelines dehumanize patients. Alex has mentioned, I love the observation that there isn't a SNOMED code for suffer.
Yeah, I think we're being gaslit a bit. You know, this is not, I think guidelines were never intended when they were written to take this much prominence. They're really useful when you're busy, and you know, perhaps AI will replace all of this, but they can be really useful, but not in the way of using them, I think, as rules. Because you know, people don't come in and they're not heart failure or COPD. They're Mr. C, who's got a whole life story, who happens to have these conditions as well, in the context of a, you know, a much richer overall life. And I think we're kind of looking at it in the wrong way. So, you know, and I think perhaps that it kind of contributes to why we're as busy as we are. We're kind of all busy running around, you know, feeding the factory, doing all these different jobs without thinking and pausing about whether how much of it matters, how much of it is useful for people we're trying to treat. I find it, you know, as a sideline, I find it really interesting that this all this public support for assisted dying, and yet we're kind of, you know, what we're doing in healthcare. And see, I'm based in primary care, but it's happening in secondary care everywhere. Is not asking these questions. So people who are within a couple of years of dying get loads of interventions, which really carry very little absolute benefit, probably. Um, you know, so I'm going to argue now that relationships are a way in which we can reduce complexity, the complexity that we meet all the time. If anyone's working in healthcare, it's complex and it's uncertain, and anybody who tries to make it any other way is selling you a false story. So I would argue that relationships are a way to reduce failure demand. And, you know, I think maybe it's not so contentious to argue that really Mr. C doesn't need a 72-hour monitor and a trip to an A&E 30 miles away. You know, more than that, he needs a clinician whom he trusts, with whom he has a connection, who can help and, you know, empower him to navigate these murky biomedical waters to get to where he and his family want to be. I think the burden placed on the system that's generated by an absence of relationships and relational care is immense. And I think if you really drill down into it, and I don't think anyone necessarily has, but I'm just trying to figure out myself, because I'm, you know, still working as a GP, how much failure demand constitutes as a what percentage of our work it constitutes. You know, if you really think about it, but a lot. So just kind of talking about relational care again. I think the thing is that if you have a relationship with somebody, like I did with the fictional Joan, who's based on someone I know, but who's not called Joan, and the details were changed, I think you kind of start to feel responsible for them. And that changes what I'm going to do. Like I might go the extra mile, I might really take on a little bit of extra risk instead of just sending her off down, you know, a warren of different tests and referrals. I might kind of think and consider what impact it'll have on her, because it's, you know, it's really, like, at the very least, it's very inconvenient to go to lots of different hospital appointments, and at worst, it kind of like reshapes your identity. You become like this institutionalized patient who stops realizing that you've got agency of your own. I think if you talk to population health experts, you know, it's estimated that healthcare contributes about 20% of overall health. So 80% isn't to do with anything we're going to do. And people have agency, and they've got what Javi Carrel calls creative capacity. So I think, you know, relational care might mean making decisions that are based in morality rather than on guidelines. And perhaps that's where soul comes in. it's what allows clinicians to make moral and sometimes brave choices in which the person and not the disease is privileged. So, perhaps relational care is soul work. I'm going to kind of, maybe I could pause again. I've never used this forum before. And so I kind of slightly feel I'm talking to my laptop. So, Ro, I'd love you to kind of
Sure. Yeah, we've got a few questions and comments. Someone's posted, sadly, payments aren't made for personalised care. Are there targets for patient satisfaction rather than clinical targets?
Yeah, we have to, not very much. So there's a family and friends test that we've got to submit data for, but it's really very light touch. So I'm in two minds, Ro, about whether it would be a good thing or not to introduce continuity of care as a target. I kind of think it would be, but there is this horrible tendency of human nature. As soon as something becomes a target, isn't there, to game the system and to make it a bit crap. I think there's actually a law about this, Goodhart's law, which says as soon as you make something a target, it becomes diminished. But I think on balance, I'd say yes. Let's try and see what happens. Continuity of care. There's a lovely patient questionnaire that was developed in Scotland by Stuart Mercer and other people, which is all about how much did you feel listened to. So it's much more than was it a good service and stuff. It's actually did the clinician who saw you understand you, or did they try and understand you? Were they listening? Did you feel that they were listening to you? So it's a much deeper kind of questionnaire than the ones that we use. So I would be in favour of it.
And someone else has written, I worry protocolized pathways risk marginalizing already vulnerable groups. For example, patients where population level data don't apply, migrants, patients from minority ethnic groups. Does this risk widening health inequalities?
Oh my God, I work, absolutely, yes. I'm so convinced of that, just on the basis of 20 years of practicing in Battersea. And I know many people aren't from London, so I'll just explain. Battersea is an area where you've got very rich people, in their in the lovely luxury riverside flats near Battersea Park, and then you've got very poor people who live in the council estates, and there's actually not a lot in the middle. And I'm absolutely convinced that the people who suffer most are the ones who live in the council estates, who don't have the same kind of agency, or aren't able. You could call it linguistic capital if you want, the ability to express your wishes. So I think people who are empowered generally in life find a way around these things, don't they? And actually they don't, until they get to a point where they're particularly frail and maybe nearing the end of life, they don't necessarily need primary care to have a relationship with them, because generally they've got lots of relationships in their life more broadly. So I think it's definitely the vulnerable people who don't fit this paradigm. So absolutely, I feel really strongly that it does exacerbate health inequalities. Um, and I'm just, for years and years, I've just been trying to find a language about this. And, I think a huge trigger for me, it's like nails on a blackboard, is to say that, well, the communication is the soft stuff. I'm telling you, it is really not the soft stuff. It is much easier for me to say, yeah, well, the guideline says this and this and this. I'm going to add this medicine and I'm going to do these tests. That's not difficult. In a world where AI is going to gain increasing prominence, I think it'll become easier and easier for that sort of stuff to be done anyway. So, in an attempt to articulate some of what I've been talking about with 3 other colleagues, we've written a series of 6 peer-reviewed articles, in which we've sort of tried to introduce this 4-domain model, just as a way to kind of validate some of what I've been trying to say. So I'd say that you've got generic skills, your generic clinical skills, taking a history, examining, generic communication skills, asking about ideas, concerns, expectations, sharing management. And then I think you have individualized application of the evidence base. So, for example, with Mr. C, this frail 85-year-old, actually, what is the evidence that a DOAC in someone who's 85 with CKD stage 4, how much absolute benefit is it going to have for him compared to the risk? And I don't have a particular position on that, but at least we're doing it. We all recognize that that's what we've got to do for Mr. C. But what about this red box where it's much more than asking about ideas, concerns, and expectations, sharing management. This is about trying to position ourselves in Mr. C's story and to try to understand him, his context, his relationships, what he wants, what matters to him, all of that stuff is in the red box. This is, if you expanded that red box, this is some of what you might find in there. It's a lot about how I'm feeling myself, right? Because, if I'm harassed and, maybe I don't really like Mr. C, maybe he's getting on my nerves because he can't hear me and I'm busy and I need to move on. All of this stuff, I kind of think that I need to be aware of it or try to be aware of it. So I think, I'm I'm feeling very trepidatious about how the world is going to be. Part of my role with NHS England, I facilitate a series of workshops called Thinking Together about Generalism. And one day one of those days, we talk about the human dimension of technology and AI. So when we first created that day, which was January 2022, so coming up to 3 years, no one had heard of ChatGPT. I could make jokes about it and kind of pretend to be me, but it was really ChatGPT and it was funny. Now that would be ridiculous. Things are clearly moving on at an incredible pace. And so for you guys, I think the world is going to be very different. We're on the threshold of entering a world where AI has the potential to shape medical care of the future. And I think that instead of getting caught up too much in the wonder of what can be done by AI, we should be thinking about what we need. And I think as human beings, we'll always need meaning. We'll always need soul. I think maybe rather than placing too much store on AI devices that can give us a diagnosis with apparent certainty, we should perhaps think about the dangers of over-medicalization, of seeing everything in terms of a diagnosis and a clear pathway. We might want to consider what the future will be like if the role of a healthcare practitioner is no longer to consider together with their patients how their symptoms fit into their overall story, what they want, what the effects of another diagnosis will be. And I think, AI could be used to open the hermeneutic window. It could be amazing. It could analyze our conversations. It could tell us when we've missed cues or when our explanations weren't understood. It could help us to understand risks and benefits. So in Mr. C's case, it could kind of give me a really good idea about those absolute risks and absolute benefits. Or I think it could shut the window permanently and we just become reduced to a kind of mass of biometric data and, running around chasing different risk profiles. Decades ago, some of you may have heard of Ivan Illich, and in his seminal work, Medical Nemesis, he offered a prescient warning about the medicalization of life, the pull towards viewing every human experience through a medical lens. And he wrote that this could lead to loss of agency and over-reliance on experts and the diminishing of our capacity to self-care. Fighting to hold on to relational care and meaning-making in our work is an antidote to a dystopian future that I don't think is inevitable, because the culture isn't fixed. It's created by multiple small interactions we have every day with our patients, our colleagues. And I wonder what would happen if we were to change the language we use with each other so that it's about values, about relationships, and not about outputs and targets. And if we were to acknowledge and validate the feelings generated in clinicians by patient encounters, if instead of suppressing emotions as though there's something to be ashamed of, if we let ourselves feel, that the story I said at the beginning is not absolutely true, but it's really based on real life, and it's those moments that absolutely pull me in. It doesn't burn me out. I think we need to redefine what's important and what is permissible. Perhaps by finding meaning in our work, maybe we can move into what Don Berwick has called Era 3. And Era 3 is a moral era, and it rejects the protectionism of Era 1, but also the reductionism of Era 2. So I'll stop sharing now, and really happy to kind of answer any comments or questions.
Thank you, Rupal. I think you've helped us sort of start to navigate the tensions between protocolized care and the balance of patient-centered care and primary care, and what the future might look like. And I think you've spoken to the soul of a lot of the participants here, because we've got quite a few questions and comments. So I think we'll get started with those. So the first one says, do you think that although emphasizing the soul is very important for ensuring holistic care for patients, could this then result in overburdening clinicians?
It's a great question, and it's one that comes up every time I talk about any of this. I'd say that there's a difference between empathy and compassion for a start. So I think what may cause burnout is empathy. And so empathy is it's a very human characteristic, is when we feel what someone else feels. So we feel their pain. But if you stay just in that state of feeling someone else's pain, then you might get burnt out. And also, it's not necessarily that helpful for the patient. If you ask patients, I think, do you want a clinician like that? They'll say, well, it starts to become a burden to them as well. Like you don't necessarily it's not necessarily useful to stay in that state. So I think compassion, the difference is it's action orientated. Compassion training, I've never done it, but I think that it involves, imagine someone that you really love, someone who's been very, very good to you, grandparent, maybe your mum, someone in your life who has treated you with real love. And imagine the feeling that you have towards them. And then you might reproduce it to someone you feel neutral about. And then maybe even to someone you feel quite negatively towards. And that feeling of kind of loving kindness is compassion, and it's not the same as empathy. And I think, but it still involves sort of being open to someone else's experience, to their story, not putting up lots of barriers. I think what evidence there is would suggest that compassion leads to flourishing and not to burnout. I don't know if that makes sense.
It does. I guess it makes me think whether we're all capable of staying on that line, whether it's easily taught not to sort of get into feeling too much that you feel burnt out.
Yeah. I think the problem with that is that you're kind of assuming that someone doesn't have anything else in their life. So by kind of feeling that all there is in their life is pain, there may be pain in that moment, and I think one would sort of feel that, but also kind of be aware that there's other things in their story other than this encounter they've got with you, and they have got agency, and part of your job is perhaps to kind of help them see that they have got their own strengths that they can draw on.
Thank you. Next question is from Jonathan, who asks, where should we focus our efforts to shift culture from Era 2 to Era 3? Do we need to change the undergraduate curriculum, the RCGP exam, QOF, the GP contract, or should we focus on our own individual behaviour and our own GP surgeries?
I love that question. I've been I've been trying to do a bit of everything. I don't know the answer, but there's amazing things happening. I was invited to go to this. It's a group of medical students. They've formed a group called Rethinking Healthcare. Has anyone here come across this? They're on LinkedIn. I can share the details. But they, as a group of medical students, they've managed to get the ear of a huge number of people. So they had an event at the House of Lords, and because I've been linked in with them, I went along, and it was so impressive. That you had the chair of the Royal College, heads of NHS England, all kinds of very important people, all listening and agreeing with what they were saying. So I think, and there's all kinds of very strong forces, I think, in every sphere, because it's, I think this is sort of the zeitgeist. I think that there's a lot of people who are feeling this, and we're just developing a language to kind of articulate what we're saying. And, in a world that's very era two dominated. So I think I'd agree on all of those levels. Definitely, you can change what you do. When you've got someone in front of you, you've got a choice about how to respond to them. And then, you can change something in the practice, you can change something in a bigger sphere, just depending on how much energy you've got, I think.
And on that note about undergraduate medical education, we have quite a few students in the room, and one of the students asks, they want to ask how and why you decided to pursue this field, and any advice you have for a medical student who is starting off in their journey and considering primary care as a career option, wanting to be mindful of using guidelines, but also providing personalised care for patients.
I don't want to virtue signal, or kind of, I know that it's not the same for me as it is for someone who's starting off. Like, from my point of view, I love what I do, and I only love it because of the connections and the relationships I have. I don't love it because I know nice guidelines off by heart. But on the other hand, when I started off my career, as well as being a GP, writing hot topics courses and guidelines and things. I think it's a very good idea to have a sound clinical base, because it makes the other stuff easier, and you'll be less challenged. I think be yourself. Like, is that a bit of a cliche or a bit trite? I don't know, but I think forcing yourself to be this kind of artificial person on the slide that I showed at some point, and just representing the system and thinking that you're just there to convey rules to somebody, that's not what the job is, and it's not what people will thank you for. Definitely won't protect you from getting complained against. Most GMC complaints relate to communication breakdown and failure of relationships. That is hard fact. So I think enjoy. It's a relationship. That's what it is, and I think people who love their job, appreciate that.
Thank you. Next question is from Adam. Is there a tension between transactional and transformational care? Transformation requires soul, but some patients, some of the time, just want transaction.
100%. I think, I mentioned in Battersea, a lot of people who are registered with us, really, they've got a lot of other people in their life for emotional support, and they want a transaction, and I'm going to give it to them because it frees up more of my time to spend with people who, where soul work is relevant. So I think it would be really arrogant of me to try and impose this on anyone who doesn't want it. They've got 5 minutes in between, work commitments to come and get something from me, and that's fine. But it's just noticing the people who fall through the cracks, and kind of knowing the difference.
Thank you. Next question is from Adam, who is bringing us down to earth and asking us, how is relational care sustainable in the face of a profound workforce crisis, 112,000 vacancies across the NHS, projected shortage of 10 million healthcare workers by 2030.
None of this is easy. I wish I had solutions. I think that we should be pushing in general practice to remove an awful lot of the targets because they don't make sense. They're not even evidence-based. I think that if we actually validate the importance of relationships within healthcare, it'll become a more joyful place to work, and then you won't get so much attrition. People will have a chance to flourish. I think there's going to be new ways of working as well. Creative health, working with local voluntary sector organisations, kind of taking a more community-focused approach. So I think there's a possibility for change, but if it's more of the same, and there's just another kind of like 5 new targets every year, and it's just the same paradigm on and on, then I agree, it's really hard.
Next question is from Jonathan, who comments, I argue that relationships precede the things that are relating to each other, which is to say that things, people, are created in relationship between colleagues and between clinicians and patients, and between groups of patients. And yet policies, protocols, and philosophies are directed at people and things rather than relationships. What kind of policies would you introduce to focus on the quality of relationships?
So I think there is genuinely a tension between using, if you want to call it left brain and right brain, however you want to term it, but kind of quantitative methods to assess something as as complex and nuanced as a relationship. But if you were to, then as I mentioned, you've got things like Stuart Mercer's care measure, which I think really tries to capture some of that. You've got measures for continuity of care. We had that little interchange before, and perhaps that should be more valued. I think I would actually go through and remove any clinical target that's not got a good solid evidence base, and there's plenty of those. And also there's just ridiculous things like measuring HbA1c in 90-year-olds who are at risk of diabetes. There's loads of things that put a huge pressure on the system that could honestly be removed and just leave a bit more room. I think ideally you'd have, if you're having targets, it would be over a longer period of time and it would be a bit more meaningful, like actually what kind of innovative work are you doing with your local community? How are you finding people the missing ones, the ones who don't kind of naturally engage with healthcare? What are you doing to help people who find it difficult to be heard? And they kind of it will require a bit more trust, but also a bit more time. There's no point in saying, we're going to announce this in September and you've got until March and, we'll decide on funding at some point. I think if it's meaningful, it's got to be much more long term. And I think that is a big problem with health policy.
Thank you. We've got an anonymous comment saying, today I had a conversation with someone working in the high intensity user service. He said that his workload had changed over the last 1 or 2 years, with having more vulnerable elderly patients who are unable to access primary care and ending up in A&E. We acknowledge that the way in which we are changing access to healthcare, i.e. with digital access, does not meet everyone's demands and can exclude some people. Failures in making primary care accessible for some vulnerable people can lead to high demand elsewhere in the system, such as A&E.
Absolutely, classic failure demand. It shouldn't be like that. We need to have a primary care system where relationships are the bedrock, and it's been done before, so it can't be impossible. If you're frail and vulnerable, you need to have a clinician who's competent and who knows you, and this kind of fragmentation is highly inefficient.
Jonathan's commented, I used AI to listen to my consultations and to transcribe and code them, and it was unable to pick up on the meaning behind the words.
I think we're some way off, but Honestly, I think the technology is probably out there. It's just a question of us, perhaps kind of like articulating what we want. I'm sure, within a couple of years, it's going to be there. I mean, it's incredible already, isn't it? That what's happened in the last 2 years. So I'm sure that all of these things are going to be possible.
And I'll just end on a final comment. Thank you so much for reinvigorating and inspiring talk. These sorts of discussions are exactly what is missing from GP training and routine practice. My trainer used to get frustrated with me for not running to time, encouraging transactional care. Just ask them what they want and give it to them.
Don't be gaslit. That's rubbish, and you stick to your guns.
Rupal, thank you so much for your time this evening.
Thank you so much for having me.
So just before we end off, just a couple of notices. I'll just bring up the screen. So we look forward to seeing you again on the 17th of December, where we will be joined by Dr. Heidi Phillips, who's the RCGP Clinical Advisor for Neurodiversity and Associate Professor for Primary Care at Swansea University Medical School. She'll be talking us through her journey to becoming a neurodiversity specialist GP, supporting neurodiverse patients in primary care, and the importance of recognising neurodivergence. All the seminars will be available online if you're unable to join live. And as always, we welcome and value your feedback as we continue to develop the series. So please do use the QR code to provide feedback for this evening's session. And the link will be sent to attendees in due course. Thank you for joining us, and good night.